Dear colleagues, thanks very much for your kind invitation, and you gave me this title, the CIS Origin and Aggressiveness. Because of the short time period, because of the big subject, I condense my message to you by referring to a wonderful children's book. Dr. Seuss wrote it. I'm sure you're familiar with it. Too Many Daves. This book deals with a smart-looking woman who had 23 sons, and she named all of them Dave. This is Dave, this is Dave, very different children, same name. And that wasn't a very smart thing to do. Because when she wanted to talk with this David, come into the house, I want to talk with you. She didn't get one, she got 23 on the run. And that caused a chaos. Imagine, so many Daves. And so now she feels sorry that when they were born, she didn't name them A and B and C, that is, different names to different individuals. And she thinks that it's too late now. Why am I telling this to you? Because we radiologists created a revolution by finding cancers early, and the surgeons understood a significant change, a paradigm shift. The oncologists changed, the radiologists changed, nurses, everybody. But the pathologists didn't change. And so let me rewrite the book. Dr. Breast Pathologist had 12 sons, and she named them all DCIS. Is this different from this, from this, from this? Yes, very different. But mind you, it's the radiologists who find them, and we learn very quickly. If this is DCIS, next time when I see something like this, I call DCIS. But next time I find calcification, and still I get the diagnosis, DCIS. And this is one type of calcification very different from this one. Very different from this one. And it wasn't a very smart thing to do, to use the same term to describe so many different diseases. Why? Because when breast pathologist wants to call this DCIS to the tumor board, then she doesn't get one, but 12 on the run. So which one are we going to discuss today at the tumor board? My lecture is meant to be a wake-up call for the pathologists. Why don't you call them according to the site of origin? This one originates from the terminal ductal lobular unit, and it's called grade 1 cancer in situ within a terminal ductal lobular unit. And this one is not even in situ. It's duct-forming invasive carcinoma. This one can be a grade 1 cancer in situ. And radiologists, never give up. We have to train the pathologists. And the most important message of my lecture is that DCIS is an outdated term in the era of modern imaging and histopathologic techniques. About 45 years ago, in Davis, California, Dr. Jensen and Dr. Wellis, who invented the 3D histopathology, wrote the following. Read carefully. Ductal carcinoma in situ originates in the lobule. The lobule where the milk used to be produced has these cells, and 75% of all cancer originates from here. It's called acinus or acini. And the steady accumulation of the cancer cells within the lobule form larger ovoid structures. Look at this, three-dimensional histology. And they fool the pathologist that these small acini are actually ducts, and it's not. So the accumulation of cancer cells within the terminal ductal lobular unit It's cancer in situ, but it's not ductal. That was so ingenious 45 years ago. Pathologists just didn't listen to them. So that's why when a cancer originates and accumulates within the terminal ductal lobular unit or lobule, or within ducts, both of them are called CIS and DCIS. So my colleague, pretty upset, says, cannot the pathologist distinguish between a stick and a ball? We came up with the idea to solve the problem. Why don't we term breast cancer according to the site of origin? After all, the mammogram is nothing else but a reflection of the underlying histology. Dear colleagues, this is a very important message for you. Here is the terminal duct. Here is the milk factory with its 50 fingers called acini, lobule, terminal duct, terminal ductal lobular unit. 75% of cancers originate from here. So calling it a DCIS is actually a professional mistake. Yes, it's an in situ carcinoma. But is this a duct? No, it's not. When the cancer in situ, grade 1, powdery calcifications, or in situ, grade 2, originate from the acini, it's acinar adenocarcinoma of the breast, cancer in situ within a TDLU. And when the basement membrane is dissolved and we got the circular lesion, here is the mammogram, here is the 3D pathology, or we got the stellate lesions, pathologists very casually call them invasive ductal carcinoma. Dear colleagues, is this a duct? No, it's not. So they are wrong. Now this is a duct, major lactiferous duct, of which these long branching calcifications develop. But what do you think? Why are they so many? They are in the duct, correct? The cancer cell originates from the ducts, but these side branches are actually invasion. So here we are talking about cancer in situ, but not ductal. Here we talk about duct, but it's not in situ because of the side branches. So it's a duct-forming invasive carcinoma. And we shouldn't even talk about this one. This is a carcinoma that never calcifies. Pathologists, again, erroneously call it invasive lobular carcinoma, but it actually originates from the stem cells of the mesenchyme. So, dear colleagues, what is important today is that you should listen less and less to the immunohistochemical biomarkers. You radiologists should listen to the imaging biomarkers. These are the second, these are the third generation modern 21st century biomarkers. And there are 4 originating from the terminal ductal lobular unit, acinar adenocarcinoma of the breast. There are 6 originating from the major lactiferous duct, and then originating from the stem cells of the mesenchyme, there is 1. Very easy to remember. So this is our suggestion for new classification. The site of origin, where you're coming from, determines your behavior. Very different if it comes from the real duct or the fake duct. That's not a duct, that's an acinus. We are lucky because 75% of the cancers originate from the terminal ductal lobular unit. And here they are, about 50 fingers, acini, produce so much milk. And this is what's happening actually. The terminal ductal lobular unit lives its own little life, and we don't know why, but one day these hardly visible tiny acini become very distended because this red, the cancer, is accumulating. They die into the lumen. If the radiologists are lucky, then we are going to see calcifications. And here it is. Any pathologist in the world would call it DCIS. But every pathologist is wrong because this is a lobule. So your radiologist come with the X-ray tube, and this is what you're going to get. So radiologists, when you see them cluster, multiple cluster, and you got the diagnosis after core biopsy CIS, you should know the pathologist is wrong. Actually, this is happening in real time. You see the intraluminal pressure is increasing, the fingers are gone, and here are the calcifications. And this is lobular carcinoma in situ. So this is not ductal carcinoma in situ grade 1 or grade 2, and this is lobular cancer in situ. Everything happens within the lobule. How can I give you a lecture about the CIS when there is no such disease? Because when it's ductal, then it's actually invasive. When it's lobular, it's in situ, but it's not ductal. Once again, radiologists, when you see these calcifications discernible, this is what's happening. You see the accumulation of cancer cells, necrosis in the middle, and then if we are lucky, we have the calcification. These are the pleomorphic or stone-like calcifications. But if the cancer cells produce fluid, and within the fluid, beautiful crystals are formed called some body-like calcifications, then we got these powdery, cotton ball-like calcifications. Terminology: acinar adenocarcinoma of the breast, grade 2, cancer in situ. Grade 1, cancer in situ, acinar adenocarcinoma of the breast. As soon as the pathologist uses this term, then she is talking with the imager who finds it. Next week, you are going to find this case, and my suggestion would be, don't look at the shape and the density. Look at the location. They are not long, so they might be within a terminal ductal lobular unit. They are indeed. You go to the tumor board, they are not going to show you all this. They just show this one. So kindly ask the pathologist, show me the lowest magnification because that matches my mammogram. So you see, this is a TDLU. So why did you call it grade 2 DCIS? Wrong. Grade 1, grade 2, cancer in situ, acinar adenocarcinoma of the breast. Here is the match with the 3D, like rolling stones in grade 2, cancer in situ within the TDLU. But beside it, there are these some body-like calcifications, and when we magnify it and use the Alcium blue staining, the cancer cells are producing fluid. And within that fluid, you're going to get these some body-like calcifications that are too small for you and for me to see individually. Therefore, hundreds and hundreds of them give this cotton ball-like appearance. I hope you understand the underlying pathophysiology. These women don't die even if there will be a 1 to 14 millimeter stellate or circular lesion beside them. You have never seen 40-year follow-up of these cases. Look at the numbers. This is the success story of screening. But the sad thing comes when we go down to the major lactiferous duct. As you see, the duct is already distended because this micropapillary carcinoma is there. I refuse to call it DCIS. The TDLU is intact. The carcinoma is going to be diffuse. Fills the entire lobe. It's diffuse. We have a problem because the duct is pleated and it allows to distend. So you see the TDLU is still intact and it doesn't calcify yet. It takes years before it calcifies. A duct normally looks like this, and its job is to run the milk to the mouth of the kid. But what is this? This is new duct formation. Disorganized. Neoductgenesis. From nature, you can see comparisons. This is how the side branches are developing. And please ask your pathologist to use the tenosyne staining demonstrating neoductgenesis. That is, the cancer cells drilled themselves through the basement membrane. The epithelial cells become mesenchymal cells through transition. Here we see this desmoplastic reaction and the lymphocytic infiltration. Dear colleagues, these are the signs of neoductgenesis. When you see this picture in front of you, you know that they are too close to each other. They are tortures. They are surrounded by the desmoplastic reaction and the lymphocytic infiltration. This is not DCIS. And in Mother Nature, in your hot environment, you see these newly formed duct-like structures. And on the mammogram, a woman doesn't have these large number of ducts. These are made by cancer. Dear colleagues, this is normal, and this is normal, and this is, but this one is neoductgenesis, but your pathologists call it DCIS. And there are 6 presentations. 4 of them have calcifications, and 1 has the bloody nipple discharge, and the other one architectural distortion. Dear colleagues, these kill women, so you cannot call this DCIS. 30% of them die despite modern treatment. Please understand neoductgenesis. Accept that this is a stem cell carcinoma, which explains why it's resistant to radiotherapy and chemotherapy. These are all very important new knowledge. What is our suggested terminology? If you see on the mammogram clustered, powdery, or crushed stone-like calcifications, please call them cancer in situ, AAB, within the TDLU. These are not DCIS and they don't kill the patient, and we can stop it in screening. But when you see this picture that is on the mammogram, the casting type calcifications like this, and too many, you should know that this is a cancer originating from the major lactiferous ducts, and 30% are going to die, whatever you do, screening or in treatment. Pathologists are referring to the myoepithelial cell layer or the basement membrane. But look at the shape of the duct. It should look like this. Why does it look like this? Because it's made by cancer. Here is an article from Harvard University. These are not myoepithelial cell layers, not the normal. It's abnormal. It's fake. It's made by cancer. We published this a long time ago. We wrote books, award-winning books. We wrote 3-dimensional books, 15 of them, and it seems to us that radiologists are learning, surgeons are learning, pathologists are still back at the time of Virchow 200 years ago. In the remaining little part of my time, I'd like to make a laughing stock of the pathologists. We wrote a book, Prostate and Breast, Brother and Sister Organs. Dear colleagues, one of them is the breast and one of them is the prostate. Tell me which one is which. You cannot make a distinction, right? This is breast and this is prostate. If I show you the cells, which one is the breast and which one is the prostate, you cannot make a distinction. In the prostate, they would never call it in situ. Actually, they call it DAP, ductal adenocarcinoma of the prostate. That's a killer. But in the breast, they call it DCIS, despite the similarity. Why? Experts in diagnosing prostate cancer take the anatomic site of origin to describe the cancers originating from the gland producing the fluid. This is the front page of the pathology journal, duct-forming invasive adenocarcinoma of the prostate. Dear colleagues, this is a prostate specimen. Malignant type calcifications. Look like DCIS in the breast, but it's not. It's a very aggressive carcinoma that infiltrates the urinary bladder, the muscles, and it actually killed the patient. Infiltrates the muscles. Here it is. This is what it looks like in the prostate, and this is what it looks like in the breast. Which one is the breast and which one is the prostate? In the breast, they call it DCIS. In the prostate, they call it a killing cancer. Indeed, it does kill patients, but it kills in the breast too. So why don't we just borrow the smart move of the pathologist and call it AAB in the breast and AAP in the prostate? Finally, at the end of my lecture, let me show you an even more very frustrating thing. What is this? DCIS? No, this is in an axillary lymph node. The term DCIS is really not only outdated, but it's a laugh. Here is axillary node with malignant type calcifications. Looks like DCIS? Yeah, but it's in the lymph node. How did it get there? Well, neoductgenesis. This is a case from Lynchburg, Virginia. Lymph node full of DCIS-like structures. Look at this. This is a lymph node, dear colleagues. Stop talking about DCIS. This is an invasive carcinoma. And the pathologists are guilty because although we radiologists can see through the whole breast, they give you only 4 micron and they give you this tiny little chopped onion-like thing. Why not doing large section as I showed you? This is modern histopathology, 21st century. Don't do this. Stop doing it because you arrive at misnomer. This should be the size of a histopathologic slide or a mega cassette. They do it in prostate. But as soon as breast comes into the laboratory, they go back to this. Which one is bigger, the breast or the prostate? Half a year ago, an article was published from San Diego University. Ductal carcinoma in situ, pre-invasive disease, lethal. This is oxymoron, because the colleagues believe that the pathologist's report is correct. Dear colleagues, I cannot give you a talk about the CIS because that's a misleading misnomer. Whenever you use the word DCIS, you should understand that you don't know what you're talking about. Please don't ever use that. Thank you very much for your attention.